Pancreatic cancer kills more seniors every year than colon cancer. Read that again, more than colon cancer. And yet the overwhelming majority of people over 60 have never once, in any routine checkup, in any annual physical, in any conversation with any doctor, been warned about its early warning signs. Not once. Here is what makes that silence genuinely deadly. The symptoms of pancreatic cancer appear months before this disease becomes untreatable. Months. They are happening right now inside people who are sitting in their living rooms attributing them to getting older. People who think their back is just acting up again. People who think their stomach has been off lately because of something they ate. People who think they are just more tired than usual because they are not sleeping as well as they used to. People who are in the window where this disease can still be caught and treated, and who are moving through that window without knowing it is closing. Here is the number that should stop you cold before anything else in this video does. Pancreatic cancer has an 11% survival rate. 11%. Not because this cancer cannot be treated when it is found early. Not because medicine has no tools for it, because it gets caught late, almost every single time. The disease hides inside symptoms that seniors have been taught to call aging, and by the time imaging confirms what the symptoms were trying to say for months, the window where treatment changes outcomes has already closed. What you are about to learn are 8 specific symptoms that pancreatic cancer produces while it is still beatable. Every one of them appears before this disease reaches the stage where survival statistics become conversations rather than possibilities. Every one of them is currently being experienced by people who have been given the wrong explanation for it, and at least one of them, almost certainly, will be familiar to you or to someone you care about before this ends. Pay attention to all 8. Do not skip ahead. The 5th one has never appeared on any symptom list any doctor has ever handed a senior patient, and it has a body count that demands your attention. Everything before it is building toward understanding why that one matters as much as it does. The first symptom is dark urine, and the reason it matters is not what most seniors think it means. When most people notice their urine has turned dark, they do one thing. They drink more water. The urine lightens. They conclude the problem was dehydration, and they move on. That conclusion, made millions of times by millions of seniors over the last several decades, is the exact response that allows this disease to continue undetected while it is still early and still treatable. Here is what is actually happening inside the body when pancreatic cancer produces dark urine. The pancreas sits directly adjacent to a structure called the bile duct, a tube that carries a substance called bilirubin from the liver into the small intestine. Bilirubin is responsible for the normal pale yellow color of urine and the normal brown color of stool. When a tumor grows in the portion of the pancreas called the head, which is the most common location for pancreatic tumors, it expands into the space around the bile duct and compresses it. As the compression increases, bilirubin flow through the duct is restricted. Bilirubin backs up into the bloodstream. The kidneys, doing what kidneys are designed to do, begin filtering it out through urine. The result is urine that shifts from pale yellow toward deep amber, brown, or the color of strong tea or cola. The critical detail that separates this from simple dehydration is the pattern. With dehydration, drinking water lightens the urine and it stays lighter. With bile duct compression from a tumor, the dark urine returns. You drink water, it lightens temporarily. The next morning it is dark again, because the blockage is still there, because the tumor is still there. Water does not remove a tumor. If your urine has been cycling between dark and normal for more than 2 weeks, regardless of how much water you are drinking, that pattern is not a hydration issue. It is a conversation that needs to happen with a doctor this week, not at your next scheduled appointment. This week. The second symptom is pain. And the reason it is more dangerous than dark urine is that it has already been given a name by most of the doctors who have seen it. The wrong name. Pancreatic cancer pain gets called arthritis, a pulled muscle, an old injury flaring up, acid reflux, sometimes all of those in the same appointment. And while the wrong diagnosis is being treated with the wrong medication, the disease is buying itself more time. Pancreatic cancer pain has a specific signature that distinguishes it from all of those other conditions if you know what to look for. It begins as a dull, persistent ache in the upper abdomen, not the lower belly, not the sides, the upper abdomen directly below the breastbone or slightly to the left. And it does not stay there. It radiates. It wraps around the midsection and settles into the middle back in a pattern patients consistently describe as a band being tightened slowly around the torso. This radiation pattern exists because the pancreas is surrounded by one of the densest concentrations of nerve tissue in the entire abdominal cavity. When a tumor presses into those nerves and invades the surrounding tissue, the pain signals travel outward in multiple directions simultaneously. The back feels it, the abdomen feels it, sometimes the shoulders feel it. The pain seems to come from everywhere and nowhere specific at once. 3 details separate this from ordinary back pain. First, it worsens significantly in the 30 to 60 minutes after eating a meal, not immediately during eating, but in the period that follows. Second, it becomes significantly worse when lying flat on the back. Many seniors with this symptom find themselves sleeping in a recliner or propped on multiple pillows without fully understanding why lying flat has become intolerable. Third, it does not respond to the treatments that work on ordinary pain. Anti-inflammatory medications, heat, rest. The pain returns in exactly the same pattern because the cause is not mechanical or inflammatory in the ordinary sense. If this pattern is familiar, the conversation with a doctor needs to include 4 specific details delivered precisely. Upper abdominal pain that radiates to the back, worsens after meals, worsens when lying flat, does not respond to pain medication. Those 4 details together redirect the diagnostic process in a way that vague descriptions of back pain never will. The third symptom is early satiety, feeling completely full after only 2 or 3 bites of food. And it is more dangerous than either of the first 2 because it is actively starving the body while appearing to be nothing more than a reduced appetite. Almost no one connects this to cancer. Seniors attribute it to getting older. Families attribute it to reduced activity levels. Doctors, when it is mentioned at all, often attribute it to a slowing digestive system. Meanwhile, a tumor is physically compressing the stomach from behind. The pancreas and the stomach are in direct anatomical proximity. When a pancreatic tumor grows and expands beyond the pancreas itself, it pushes against the posterior wall of the stomach. The stomach's physical capacity is reduced by the external pressure. It fills with a fraction of its normal food volume and sends fullness signals to the brain. At the same time, the tumor is disrupting the pancreas's ability to produce the digestive enzymes that would normally break down food in the small intestine. Food that reaches the digestive tract without adequate enzyme processing sits undigested for longer than it should, extending the sensation of fullness. The combination of these 2 effects, reduced stomach capacity and impaired digestion, means the person stops eating not because they are not hungry, but because their body physically cannot accommodate normal quantities of food. The weight loss that follows is rapid and significant. The body is not absorbing adequate nutrition from the small amounts being eaten. Muscle mass declines. Energy reserves deplete. Unintentional weight loss exceeding 5% of total body weight over 2 to 3 months is one of the most serious warning signs in all of medicine. 10 to 15 pounds lost without any intentional change in diet or activity is not a coincidence. It is not a metabolic shift associated with aging. It is a red flag that demands investigation, not reassurance. 3 bites and done is never just an appetite change. Knowing that distinction is the kind of information that determines whether something gets caught at stage 1 or stage 4. The 4th symptom is jaundice, and the reason it is particularly dangerous for seniors is that it looks identical to one of the most common conditions affecting people over 60. Jaundice occurs when bilirubin backs up so significantly in the bloodstream that it begins depositing in body tissues. The skin takes on a yellowish tint. The whites of the eyes turn yellow. In people with darker skin tones, the yellowing is most visible in the eyes and in the palms of the hands. Alongside the visible yellowing, bilirubin depositing in skin tissue irritates nerve endings directly, producing intense, generalized itching across large areas of the body with no rash present and no relief from antihistamines or topical treatments. The itching is relentless because its source is internal and cannot be reached by anything applied externally. Here is where misdiagnosis becomes most likely. Gallstones, which are extremely common in people over 60, produce jaundice through bile duct compression that is clinically indistinguishable from jaundice caused by pancreatic tumor compression. Same yellowing, same dark urine, same itching. A doctor who sees jaundice in a senior patient and knows that patient has a history of gallbladder issues will frequently pursue the gallstone diagnosis first. Weeks of investigation focused in the wrong direction can pass before imaging wide enough to visualize the pancreas is ordered. This is why presenting a complete picture matters more than presenting any single symptom. Dark urine cycling back despite adequate hydration, upper abdominal pain radiating to the back, and worsening after meals, early satiety with significant unintentional weight loss, and now yellowing of the skin or eyes, together tell a story that no single symptom tells alone. That combination demands imaging of the entire abdominal cavity, not just the gallbladder. The fifth symptom is the one with a body count, the one that has sent seniors to emergency rooms with life-threatening events before a single physician connected what they were experiencing to their pancreas. An unexplained blood clot. Think carefully about whether you or someone you know has experienced a blood clot in the recent past with no clear explanation, no recent surgery, no extended period of immobility, no obvious risk factor that the treating physician could point to, because what that blood clot may have actually been is the earliest possible warning this disease produces, appearing in some patients 6 months before any other sign of cancer is detected. Pancreatic cancer releases specific proteins into the bloodstream that fundamentally alter clotting behavior. The blood becomes abnormally prone to clotting in situations and locations where it should not clot. The most common presentation is deep vein thrombosis, a clot forming in the deep veins of the leg. The calf or thigh swells. The affected area feels warm to the touch. A dull, heavy ache develops that does not improve with elevation or rest. The life-threatening dimension of this symptom is what can happen next. A portion of the clot can dislodge from the vein wall and travel through the bloodstream into the pulmonary vasculature, the blood vessels of the lungs. The result is a pulmonary embolism, sudden shortness of breath without exertion, sharp chest pain that intensifies with each breath, heart rate spiking without physical cause. If those three symptoms appear together, the response is not a call to the doctor's office or a visit to urgent care. It is an immediate call to emergency services. This is a life-threatening emergency measured in minutes. Research examining pancreatic cancer cases has found that in a meaningful percentage of patients, an unexplained blood clot was the first detectable sign that the disease was present, sometimes appearing half a year before the cancer was identified through any other means. 6 months of additional detection window, potentially enough to change the staging and therefore the survival outcome, lost because no one in the care chain connected the clot to the pancreas. If an unexplained blood clot has occurred recently, the direct question to ask a physician is whether abdominal imaging has been considered, not as a panic response, as the medically appropriate next step given what the research now shows about the relationship between unexplained clotting and pancreatic malignancy. The sixth symptom runs on a cycle, and that cycle is exactly what most seniors miss because they interpret each episode individually rather than recognizing the pattern. A fever on Tuesday, it passes. Another fever on Thursday, it passes. The assumption is a minor illness circulating in the household or community, but a minor illness resolves and stays resolved. This keeps returning because the immune system is not fighting something it can defeat. It is responding to a disease that is not going anywhere. Pancreatic cancer produces persistent internal inflammation. The pancreas itself is inflamed, the bile duct is obstructed, bile is accumulating in locations where bile does not belong. The immune system responds to all of this continuously. The result is a pattern of recurring low-grade fever that cycles in and out without ever fully clearing. The fever itself is not dramatic. It does not reach the high temperatures associated with serious bacterial infection. It registers in the range of 99 to 100 degrees Fahrenheit, high enough to produce the generalized feeling of illness, but not high enough to feel acutely sick. What accompanies it is as important as the fever itself. Episodes of intense chilling, feeling cold to the bone in a warm room, shivering without environmental cause, arriving before the temperature rises, and night sweats, waking in the early hours damp from perspiration without having been warm when falling asleep. The combination of cycling low-grade fever returning over multiple weeks, episodes of unexplained chilling, and night sweats is a combination that demands investigation extending beyond the prescription of antibiotics or antivirals. Fever cycling back for weeks without an identified infectious source is not a fever problem. It is a signal that something internal is generating ongoing immune response. That signal deserves imaging, not repeated short courses of medication that treat nothing related to the actual cause. The seventh symptom is fatigue, but not the fatigue that responds to rest, which is the specific and critical distinction that separates cancer-related exhaustion from ordinary tiredness. Normal fatigue has an identifiable cause, a poor night of sleep, physical exertion, sustained stress, and it has a remedy. Rest fixes it. The quality of the recovery is proportional to the quality of the rest. Sleep 8 hours and wake feeling restored. Sit down for an hour and stand up feeling meaningfully better than before sitting down. Cancer-related fatigue operates on a completely different principle. It does not respond to rest because its cause is not exertion or sleep debt. Pancreatic cancer cells compete directly and continuously with healthy cells for glucose and nutritional resources. The body's supply of fuel is being intercepted at the metabolic level before it reaches the organs, muscles, and brain that need it. The body runs on a continuous deficit not because it is not receiving adequate nutrition, but because what it receives is being diverted before it arrives. No amount of sleep closes a deficit caused by ongoing biological theft at the cellular level. The qualitative character of this fatigue is distinctive in ways that people who experience it consistently describe in similar terms. It feels heavier than ordinary tiredness, more total, more unresponsive. Tasks that were never a source of effort become effortful in a way that feels disproportionate to their actual physical demand. Walking to the end of the block, carrying a bag of groceries from the car to the kitchen, climbing a single flight of stairs, the effort required feels categorically different from what it felt like performing the same tasks months ago, and rest between efforts does not restore capacity the way it used to. If that description matches what has been happening for the past several weeks, the cause deserves investigation. Accepting this level of fatigue as a feature of aging is exactly the response that allows the underlying cause to continue progressing undetected. Fatigue that does not respond to adequate rest is not a rest problem. It is a metabolic signal that the body is losing a competition it is not supposed to be having. The eighth symptom is the one that appears in the bathroom, the one that almost no one talks about, the one that has been present in nearly every advanced stage case, and that every one of those patients attributed to something they ate. The pancreas produces enzymes specifically designed to break down dietary fat in the small intestine. When a tumor obstructs the pancreatic duct, those enzymes cannot reach the small intestine in adequate quantities. Fat consumed in the diet passes through the digestive system substantially undigested. Undigested fat changes the character of stool in ways that are visible, unmistakable, and entirely different from any dietary effect. The stool turns pale, gray or clay-colored instead of its normal brown, because the bilirubin that normally gives stool its color is no longer reaching the intestine in adequate amounts. It develops a greasy quality, an oily sheen that is visible when examined. It floats in the toilet bowl rather than sinking because of its fat content, and it produces an odor that is distinctly more foul than anything that could be attributed to a particular food. These characteristics together represent a direct mechanical communication from the pancreas. They mean the pancreatic duct is obstructed. They mean fat is passing undigested. They mean the fat-soluble vitamins that the body requires to maintain immune function, bone density, neurological health, and dozens of other critical processes are also not being absorbed. This accelerates the weight loss described in the third symptom. It accelerates the fatigue described in the seventh. It accelerates every other process on this list simultaneously. Pale, greasy, floating, malodorous stool persisting for more than 2 weeks is not a dietary side effect. It is not a consequence of a particular food or combination of foods. It is a symptom that demands a phone call to a physician within 24 hours, not at the next convenient appointment within 24 hours. Now, the most important 60 seconds of everything covered here. Because knowing these 8 symptoms changes nothing if what comes next is a return to calling everything aging. Pancreatic cancer diagnosed at stage 1 is a fundamentally different disease from pancreatic cancer diagnosed at stage 4. The survival outcomes are not slightly different. They are categorically, unrecognizably different. The only variable separating those two outcomes is what a person did in the weeks after their body began sending the signals described in this video. The people who waited, who called it aging, who assumed the next appointment was soon enough, who did not want to seem like they were overreacting, those people did not get the stage 1 conversation. They got the stage 4 one, and most of them are no longer here to describe the difference. If 2 or more of these 8 symptoms were recognizable while reading, the action is specific and it needs to happen today. Write down every symptom, not a general description. The specific symptom, when it started, how frequently it occurs, whether it has been getting worse over time. Take that list to a physician and read it out loud, exactly as written, not a summary, not a general statement about not feeling well. The specific list. Specific symptoms generate specific investigations. Vague descriptions generate reassurance and a follow-up appointment 3 months away. If the response to a complete symptom list does not include a discussion of abdominal imaging, specifically a CT scan or an abdominal ultrasound, it is not overreacting to ask directly whether those investigations are appropriate given what has been described. That question is not being difficult. It is being the only person in that room who is advocating for the outcome that only early detection makes possible. The healthcare system in the United States in the summer of 2026 is under pressure in ways that directly affect how thoroughly individual symptoms get investigated in routine appointments. Primary care appointment times have been compressing for years. The average appointment duration continues to fall while the complexity of the patient population continues to rise. Symptoms presented vaguely in a 12-minute appointment slot get vague responses. Symptoms presented precisely, with a written list, with specific details about pattern and progression, with a direct request for the investigation that the symptom combination warrants, get different responses. The preparation matters, the specificity matters, the willingness to ask the direct question matters. Do not leave this and go back to calling these symptoms aging. The information in these 8 descriptions is more specific, more detailed, and more actionable than most seniors will hear from any physician in any routine appointment this year. Use it, write the list, make the call, ask for the imaging. The window where this disease is beatable does not announce itself. It does not send a reminder when it is closing. It is open now for anyone whose body is sending these signals and who is still in the early stages of what this disease becomes if it is left to progress without investigation. The 11% survival rate is not a ceiling on what medicine can do. It is a record of what happens when detection comes too late. The ceiling for early detection is completely different. The only thing that reaches that ceiling is acting on what the body has already been trying to say. You know what it has been saying now. The next move belongs to you.